This week on the Back Table Podcast.
Have that growth mindset. I mean, surgeons are the worst. Don't get me wrong. We can be very rigid. We can be very difficult to deal with. I'll own that. But I would say to not just young IRs, surgeons, but I would say also to young tech people who are trying to get into the business, you're just trying to find that person who you can hopefully collaborate and learn from. And then it's not going to be a panacea, but I don't regret it. Have I failed just as many times as I've succeeded with certain devices that I thought would work? Oh, totally. But we want to have a smaller and smaller percentage of patients who need to have that big midline laparotomy and need that 4 to 10 day hospital stay. If I could choose between a minimally invasive approach with the exact same outcomes versus a maximally invasive approach, I think we know where we would all go.
First, a quick word from our sponsors.
RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the Back Table Podcast. Now, back to the episode.
I'm Sabeen as your host today, and I'm thrilled to have Dr. Robert Martin, who's the Director of Surg-Onc at University of Louisville, join us today. Welcome, Robert.
Thank you, Sabeen. Yeah, it's a pleasure to be here. Excited to talk.
Pleasure's ours. I mean, Robert, you're a pioneer in the use of different liver-directed therapies, ablation, IRE, radioembo, and really have been instrumental in advancing these technologies as a surgeon. So, in this episode, we're going to dive into the evolution of these therapies, collaboration between surgery, IR, and other specialties, and kind of talk about some clinical trials too. So yeah, thank you for coming on. I mean, I would really like to know, a little bit more about your background, how you ended up in Louisville, and how did you really kind of get so involved in the evolution of these therapies?
Sure. Yeah, so I think I was sort of a late bloomer to oncology and surgical oncology. Really didn't kind of decide on that until my third year of residency. Luckily, because of just either contact and interest rate, as well as where I went to high school, I really wanted to go Northeast, which is very different where a lot of our general surgery residents have gone. And so went up to Memorial Sloan Kettering. And that kind of really, I think sort of solidified, my interest in, all things oncology. But because of the pioneer training that I got from Les Blumgart and Murray Brennan, really kind of solidified my passion into HPB and, was really focused and saw that type of non-competitory collaboration, at least within the HPB unit, and was all ready to stay. My wife had a great job there. We loved it there. And then September 11th hit. And then a month later, we had our first child and priorities changed. As one late night, when we were taking care of our daughter, I remember my wife saying, I'm not sure I want to live in a city that has a bullseye on it. So that's a fair statement. And so started to look around and thankfully found University of Louisville that was just starting to build their surgical oncology program. They had 3 surgical oncologists, 2 that were leaving. And so got recruited really kind of in a clean slate. So I was able to kind of build and reproduce what I saw worked at Memorial and then be able to hopefully overcome and access, what maybe didn't work. And so joined that system here, and we have a unique, probably even more atypical system here now, in that we provide surgical oncology services to 2 healthcare systems that are actually competing. Yeah. So U of L Health, but then also Norton Healthcare, which is another sort of big healthcare system there. I just came back just to take care of patients. I was luckily able to be sort of system naive or system neutral and have been very aggressive in providing surgical oncology services to both of them, keep them both happy, And that allows us actually to have sort of the size of the surgical oncology program that we have in Louisville, which, as you know, is not a big city, but we've got a fairly big division. And I think that's sort of been the background of how we've been able to sort of grow it.
That's great. I mean, were you kind of like an outsider when you came in, and then brought a lot of different perspectives coming from Sloan and then to Louisville?
Definitely. I would say more of an outsider because everyone else had been trained at Anderson.
Okay. Yeah. Yep. There you go.
So I did have to do a lot of negotiating with my division chief, Kelly McMasters, who's now my chairman. But as long as there was data behind it and there was collaboration and there was clinical trials behind it and ways to do things better, he's luckily never been an obstructionist. So that's also a foundational piece as to why I'm still here 22 years later and have never gotten bored or have never gotten kind of disenfranchised because all I get is no, 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 no. I get a lot of maybes, and then I can turn those maybes into yes.
A good negotiator. Good.
Yeah.
Was it through your experience in Sloan and everything that you got involved in these liver-directed therapies, let's say like ablation and IRE? Was there something that interested you more? Or, I mean, it's so part and parcel of HPP treatment. So
yeah, I would say Memorial, no. That was probably one of the training profiles that I didn't get there. I got kind of a taste of it my last year of residency. And so I knew I was very interested in it. And then when I came back, because, again, I was not at a big name institution, I was being referred a lot of different patients who had a very diverse, heterogeneous sort of disease pathologies. IR here was not very well established, so I just saw it as a clinical unmet need. I guess my foundational piece is that I hate to see patients in the clinic and tell them I can't help them. So that's sort of a foundational piece. And, that's either both good or bad, depending on your opinion. But I said, all right, well, I need to think of doing things differently than can I just resect? And if I can't resect, then basically kind of, say, all right, see you later. And that's really where I think why I got into ablation, and then why so quickly in 2006, I switched from RFA to microwave, just because it just overcame a lot of the limitations of the patients I was seeing, which was an equal number of both HCC as well as colorectal back then.
Okay.
Yeah.
And so you already mentioned like evolution, RFA to microwave. I mean, from your perspective, and this is probably a bigger question that can be answered in pretty briefly, but what has been the evolution of these therapies from your perspective, and how are they improving and fitting into modern surgical oncology?
It's been a fascinating kind of evolution, over the last 22 years. I mean, I did start with the original sort of Boston Scientific RFA device, that had the kind of, the roll off.
Yeah,
exactly. But because I do immediate post-operative imaging, usually that same day or the next day, my incomplete ablation rates for HCC, because they were just so vascular, were not acceptable to me. I mean, I do ablations and I hold my ablation quality like I would from surgical resections, meaning that my margin positivity rates need to be less than 3%, and my local recurrence rates need to be less than 1 or 2%. And so I couldn't get that with RFA. And so that's why, I bumped into, the original Vivant Medical, with the 915 megahertz before they were bought by Covidian, and negotiated them to come give Louisville a try. And so immediately went there because it gave me so much more immediate power to overcome that kind of heat sink effect. Now, the problem with that, though, is it put a huge skill set on both your laparoscopic skills as well as your ultrasound skills, because you had to place at least 2 or 3 needles simultaneously, and your spacing had to be pretty precise, because if not, you didn't get that synergy, and then you got some skip lesions in between where you put it. So kind of got my money where my mouth is, meaning I wanted a microwave, but it raised the technical level a bit. But that ended up serving me quite well, because then just 5 years later is when IRE kind of came out on the market, and it demanded that same degree of sort of ultrasound skill set, multiple needles, precise spacing, and then really kind of expanded that outside of just liver, but then pancreas, which is obviously was another area, kind of passionate area for me.
Yeah. And, from your perspective, like how do you decide between these different therapies? I mean, like you're weighing, I know obviously the patient condition, the location of the tumor, and then, including surgical resection or whatnot. What are some of the big take-home points you kind of have that you wish our like surgeons, oncologists, IRs that are listening today would have?
I think it's an important point. I don't see them as competing modalities. That's the short version. They are very good ablative tools for certain locations and certain sizes. And so for liver, if we just stick in liver and we kind of keep it sort of short and concise, for liver, there's really only two major areas where IRE plays a role, and that's right at the hepatic hilum. So a hilar cholangio, an atypical colorectal or neuroendocrine met, and then HCC high up, usually involving outflow. Those two areas where microwave will be effective, but the collateral damage to the surrounding structures are just not acceptable. Location is really that area, but then the caveat with IRE is that you really got to stay less than 4 centimeters. If you try and go above that, the data that we've published initially and what I've seen in the literature, the success rates they're not successful. Yeah, it's a waste. You're wasting the patient's time. Whereas microwave, it's pretty much any other segment or any other location besides that. And then, that's 5.5 centimeters or less. And that's in combination with my IRs is whether they're doing a bland embo the day before and that kind of, and that's really where all the collaboration comes in. And then whether they're doing it percutaneously or because of access, we need to do it laparoscopically because there's other concomitant procedures that we need to do. I've been very fortunate to have very complementary and collaborative IRs that there's no one stealing another one's cases, so to speak.
And you've probably seen not only the evolution of these technologies, but you said IR initially when you got there, early 2000s was not, doing anything, extraordinary, but you've probably seen that collaboration and development evolve.
Yeah, I mean, because that's a caveat to that. So part of my Memorial training was being indoctrinated into hepatic arterial infusate pumps. I left Memorial thinking
HAI, yeah.
everyone needs an HAI. I mean, and I came back here, and again, because we work with one of the healthcare systems that's more private practice, a more senior one, after I'd put about 30 or 40 in, he came to me and said, Rob, I know you like to do these pumps, but if you put more pumps in, we're not going to refer you more patients because they just didn't have the infrastructure. I mean, they couldn't manage them. It was not practice feasible for them who were trying to give systemic chemotherapy for them to be able to do that kind of aggressive. Not that they don't work. It's about your practice. And so that's why I did immediately pivot to, Y90 because I thought it was going to be and then that's why I also initially pivoted to drug-eluting beads, the original sort of biocompatibles with, the LC bead with doxorubicin and irinotecan. And I sort of trained our initial IR just to rank, patient indications and dosing and when do we retreat and all those types of things. Cause I mean, he's now retired, but he was totally open to it, but he was a good 20 years ahead of me. He did not have any oncology experience and he had basic IR experience, but he was technically very facile, so could do these procedures safe and effectively. But I had to manage all of the dosing, the timing, the collaboration with medical oncologists, and I love it. And I still like to do it. I mean, it's still, I think, a huge kind of thrill when we see that type of collaboration.
I feel that's like quite a unique relationship too, at least from my experience. Obviously a lot younger, but having the surgeonc that involved in the Y90 part, aside from deciding, okay, Y90 is an option, is great. The foundation you probably have now and have created with IR is like so close, definitely has to enhance patient care.
Yeah. I mean, I've been fortunate, I was able to kind of pull them in, and really pull them into a true weekly multidisciplinary, tumor conference, which is hard for IR to do. Because, a lot of them, it's a wasted hour, they're not reading any images, they're not doing procedures. And so I had to kind of bring them in. But then once they saw how quickly the boat was rising, then they were like, everyone wins.
Yeah. You learn so much. I mean, there's just so many perspectives. It's just,
without a doubt.
it has to be done.
You're the radiation oncologist as well. And so, but once we kind of all got into the room and I was able to show the algorithm, it's pretty easy to see that in the lifespan of the patient, everyone is going to give their treatment. And some people are going to give their treatment multiple times, especially if it's going to be IR or radiation, and then even surgery. So once people realize I don't have to always go first if the patient comes to see me first, if I just present it, that patient's going to cycle back. And then more importantly, the timing of the therapy is going to be so much more beneficial and not going to burn a bridge.
Is there a modality, from your, like, do you see a case and then you kind of in your head, you're like, do you prefer a modality over other to see like, okay, number one, can I do this? No. Then number two, can I do this? Is there a specific order or priority that you have in these treatment modalities? Obviously, surgery probably being the top. I mean, if you can resect it.
It's true. But again, as I've trained my fellows now, I mean, I would probably say that nearly 90% of the solid organ malignancies that I focus on, which are esophageal, gastric, liver of histology, and pancreas, we're treating them dramatically different than we were in 2002. And the foundational piece that we're treating them differently is vast majority of those patients are getting neoadjuvant systemic chemotherapy because they do work. Now that depends on your opinion as to what that work would be. There is some response rate, but the most important thing, it allows us really to have an assessment of the biology of the tumor. Now, to that end, I'm thinking about, what chemotherapies we can make sure we can give this patient, but I can also make sure that that patient's going to come back to me just as fit, just as surgically. And so that has opened up a whole aspect of that. If we kind of pivot into the IR space, it's really honestly about, what does the least amount of damage and what does the least amount of footprint. And so, as I always say, if you've got, 3 or 4 lesions in the liver, maybe all on the right side, but the patient's not surgically resectable, are they a Y90 candidate? Sure, they are, but that's a kind of a finite number. Let's keep that arrow in our quiver later on, because once we blast that whole lobe with set amount of gray, we're kind of burning the bridge. And so that's what I love about it, is that it taps back to sort of my complex mathematical majoring, and that we're bringing in all therapies, but we're really trying to figure out, we're really tailoring the timing of which one goes in so that we can make sure that there really is going to be first-line locoregional therapy, second-line locoregional therapy, and third-line. The one thing I don't ever want is I don't want ever locoregional therapies ever always just kick to the salvage curve.
Yeah.
You always hear that term. And that's really where I'm negotiating and educating the medical oncologists, is that these are not salvage therapies. You need to be thinking about them dynamically while the patient's on first-line therapy. Yes, 100%.
Yeah, because once you're at that stage, it's just how much benefit are you getting? As far as, recent clinical trials, I know you mentioned you're in the RADPAD trial in ABK and also immunophotonics. So can you describe some of these emerging therapies and your experience with it?
Yeah, I mean, I'm excited about them. I've always been a clinical trial massive advocate, just because I believe that patients actually get better quality of care when they're on a clinical trial, because they have a dedicated research coordinator that has to follow them, because we have to capture adverse events. And so they're calling them like every week. That's a small plug to clinical trials, but I digress. But yeah, I mean, I would say for the ABK study, I mean, the thing that I've always been frustrated with Y90 treatments and even drug-eluting beads, now slightly less with the M1 bead, but I was never able to source verify the dosages that went to the tumor. And so when the patient saw me back after the procedure, they're like, I feel great. And then they didn't work. And we're like, well, we're hoping that flow dynamics, that everything went that way. And so it gets really confusing for them. I still do the 1 month post Y90 scan, honestly, just from us. Okay. But you and I both know it's not highly predictive of response. So it's a little bit of you're kind of treating yourself. As a surgeon, I wanted the pathologic margin assessment from an IR procedure. That's kind of really where that came from. And the ABK device was the first one out there that said, wait a minute, I can get a time of flight CT PAT, within 6 hours, and we can actually then truly evaluate what that dosage is. And then, you know what, if the IR has a bad day, trust me, I've had them, and their catheter wasn't really where they thought they were, or they missed that one peripheral vessel, that's not a big deal. But if I know that 48 hours after the procedure, and I call the patient up and said, you know what, hey, we got to do something else. We got to get this other quarter. I don't see that as a failure. I see that as a massive success, because then the patient is really getting that type of optimization. And so I've been excited about that trial. It's a little bit clunky how it's been written, but my goal is to hopefully get to that point where we're able to do Y90, we're able to do hepatic arterial therapy, and within 48 hours, like we do after thermal ablation of the liver, go, yep, we are really confident this is going to respond in the next 6 weeks, and that we don't have to kind of just hope that follow-up scan is going to look as good as we want it to.
And for listeners who aren't familiar with ABK, can you describe it a little bit and the trial?
Yeah, the trial right now is an initial sort of phase 2 trial in which they have an imageable Y90 or yttrium 90 type of bead. And so patients undergo standard Y90, just like you would with TheraSphere or SurSpheres. It's a little bit technical difficult in that they really are doing just focal Y90 treatments to them. So you're getting kind of a radiation segmentectomy, or really actually a targeted therapy. So you've got 3 lesions, you're targeting that one major vessel to that lesion. So you're not doing any lobar treatments. It's truly selective to even super selective type of treatments, because they really want to be able to calculate the dose that was delivered there immediately. So then hopefully then predict that response. And so it's a limited trial in HCC, and really the inclusion criteria is predominantly patients that are eligible for thermal ablation in regards to the numbers. Where they're trying to is that they will allow you to treat up to a total tumor volume of 12 centimeters. So you can have 3 lesions. If cumulatively it's 12 or less, then they're eligible for the study. And we've had great results with the patients we've enrolled. It's been a little bit frustrating because we're going on sort of 1 of 15. There are 15 patients I screen. I've only got 1 patient that's being eligible because of that. But they're sticking with it, which I applaud them. And I'm hoping that, they'll be able to meet accrual this calendar year, and then be able to kind of then expand that use like we've been using with Y90, but get far greater degree of immediate information, so to speak.
I have to say, from an IR's perspective, it's pretty nice to have a surgeon who really understands all these kind of, radiation segmentectomy, dosing. I mean, usually that's just, I'm at a community hospital and we have very good just tumor board, but people don't understand when I'm like, okay, we can do this here. I mean, it's just nice to have other specialties understand it well.
Yeah, we put a high premium on that with our fellows. We're an outlier, I agree, probably because of my idiosyncrasies, because I just think, I do. I mean, you should know about your other therapies that you're referring to, especially when you tell a patient, hey, I need you to go get X. And then their response back is, what is that? You ought to be able to give them at least a 500-foot view, as opposed to go, I don't know.
I'll just
go
talk
see
to him. Yeah. Another thing that kind of came up, we were discussing Creators Weekend before starting the episode. One question, this whole like palliative treatment versus curative treatment. Mm-hmm. There's kind of the thought, ablation, microwave ablation, IRE, that's curative. Mm-hmm. Radio directed, radio embolization and things like that is palliative. Do you see that? We've touched on some terms already, but do you kind of view it like that? Or are you also looking for like curative treatments with radio embolization and a segmentectomy or ideas like that?
I am now based on stage. Now, I mean, I think, really, I think what we're talking about where these kind of overlap is, is sort of BCLC stage A, but more BCLC stage B based on, the number of lesions. I think, patients that have C, that have visible vein, portal vein thrombus, whether tumor or bland, I've got to be, this is where my eternally optimistic aspect starts to get, beaten down.
Sure.
But no, I'm definitely using them in a curative intent. Now,
yeah.
What do I mean that we're curing everybody and I'm telling patients that we're curing with this treatment? No, I'm not. But what I am doing is that I believe that each one of these therapies all should be effective so that the patient gets some form of benefit. Now,
Okay.
the question is, all right, well, what benefit is that, Rob? And I would say mainly that they're getting some form of break for at least 9 months so that it wasn't futile. What we've looked at, because don't get me wrong, surgeons are guilty of doing futile operations, meaning we operate, we tell them we got it all, and then 6 weeks later, they restage the scan and the patient's got...
Sure, yeah. It's everyone.
Yeah, exactly. We got to be careful with that. We've kind of set that with our colorectal, and when we looked at it with patient perceptions, most of all patients realize when they know they've got advanced disease, they know they're not going to get a cure, but they do want benefits from something. That effect and that benefit is about 9 months. So if you're able to do Y90 and they're able to come off therapy and just be followed for 2 or 3 interval sequences, knowing it's going to recur, that's, in my intent, that's a benefit. That's a curative benefit. It's not a cure, I get that, but you're doing it because you want to either allow them to stop their immunotherapy or because, they're not tolerating their TKI anymore and they know they want a break before just going on to something else, using the HCC as an example. We see this all the time in colorectal, pancreas, neuroendocrine. I mean, these same concepts is what we should, be thinking about. Not can we do the treatments, because as you know, we're incredibly safe doing these. It's should we do them, and what is the clinical benefit that we think we're going to get out of it? Do I hit that metric all the time? Of course not. Oncology is sometimes a big kick in the teeth, on a weekly basis. But you've had your successes, and that, I think, also gives you that energy to keep going.
Yeah. You've obviously, you're so familiar with the, endovascular IR side, and I'm assuming you've probably been to these conferences too. When you're there sitting as a surgeon, you did the microwave ablation course on back table. What do you see are always the points that are missing, or what we as IRs are overlooking, are not putting too much value on?
Yeah, this is going to get me in trouble, Sabeen.
It's okay. It's a don't worry, that's how we do it here.
It's a great question. And many of the IR presentations that I see, unfortunately, are too much, looky what I can do. Let me show good radiographic pictures and what I can do from that. And I think where that, unfortunately, does not remotely translate is into the oncology community. Medical oncologists, they're okay with seeing what you can do, but you got to speak their language. You've got to give the oncology specific data. And if you're not giving, at a minimum, progression-free survival, or you're not giving them when this therapy fits in the systemic therapy arm, first line, bridging first line, during second line, it's white noise to them. And I think that's where IRs had, probably the biggest challenge of getting into the sorority or the fraternities, because the language is different. And that doesn't mean you're going to do it any differently, but you're educating the medical oncologists that you know what you're talking about. And then they're able to buy in and go, oh, this is a perfect consolidative treatment. After first line therapy, they have still visible disease, but I don't really want to give them second line now. Wait, let me do a procedure to consolidate the disease we see. We know they're going to recur. We get that, but we're giving that patient more chemo-free time. Those types of languages. And I think there have been some, very, well-educated IRs that are already doing this. The consensus statements that came out from Martin Meyerlink and Goldham about making sure that every patient, based on the histology, you're giving them local recurrence percentages, total, PFS. I think we have to hold ourselves to that, because the oncologists they just don't even look at it, and they're not even going to remotely think about it.
Hey, you're totally right. And here's, talk about breakthrough technologies and then evidence. What are you familiar with histosonics? Have you seen?
Yeah. I was just about to use that as an example.
Tell me about what, this is obviously a very different technology. Their data is not that long, but what do you think about it? And how do you feel that fits in the future?
Yeah, a hugely exciting technology. incredible team that's kind of, releasing it and are very savvy, and thankfully have learned from all the mistakes of the prior technologies that have come out in the last 10 years and the fits and starts and on again, off again, like we saw with IRE. So I'm fully aware of that. So they're trying to do that. Their blessing and curses is they got FDA approval for liver tumors. And that, again, it's the same concept. I've reviewed 3 or 4 of their manuscripts, and it's all, look what we could do. We treated these tumors. 30 days later, the patient didn't die, and here's some CT scans. And I just had to reject it. I said, look, this is an ablative technology. It's going to be held to the same level as any other ablative technology. It is a different modality, and it is potentially less invasive. I get all that, but we have to have that type of oncology presentation data for the medical oncologist to then start to think about it. If not, like I said, it's going to get pushed into the dreaded salvage garbage can. And that's sometimes a really hard scarlet letter to undo or to unlearn medical oncologists to go, oh yeah, this just is just when I can't give anything more. And that's not where I think you want to be with this technology, or actually any technologies.
Yeah, exactly. I mean, because it's very exciting technology. I mean, I saw it, but I think, like, how am I going to talk to my oncologists? I mean, more so than exactly you said. Look at what this can do. This is really cool, without some long-term data. So that's one challenge, but it'll be kind of fun to see where it goes. What other any other kind of in the future, like, things that are developing on the forefront that you know of, liver treatment or other oncology treatment?
Yeah, I mean, I think where we're starting to see a little bit more movement, and again, my glass is always 7/8 full, so this could be just naive, but I am seeing a little bit more excitement around technologies in combination, especially with immunotherapies. We're luckily now with having a good 5 or 6 immunotherapy companies out there, and not just the big 3. We're starting to see that there is a little bit more excitement around local regional therapies with concurrent, immunotherapy, and really learning around that immune modulation effect. We're seeing it with IRE. There's some exciting trials going on with Y90 and that combination, aspects of that. I think the critical piece for this, and this really comes back to us as the technology users, is to make sure that we really are also getting immunophenotyping to assess which are the sweet spots patients. Because that's one thing that I would say universally all medical oncologists do respond to is marker. You say marker, you say systemic marker, they'll sit up. Right. Yeah. And so I think it's going to be imperative upon us to also identify that immune phenotype marker. I mean, we're learning more and more about patients in regards to that kind of immune exhaustion. They've gotten 4, 6, 8, 12 months of chemotherapy. There may not be as savvy around health and overall fitness and nutrition. And so their immune system just may actually be completely exhausted, and there may not be any way. And I think we need to make sure that when we do the therapies and we don't see good results, that we have some immune phenotyping markers to assess, all right, just because this patient looked okay to treat, we probably needed to, modify or improve their overall health to accentuate that. So I think we're gaining some leverage in that. It's been a heavy lift, especially with pharma. They are been really, really tight with the use of even giving, IO to unindicated organ sites. But I think we're starting to see now there are additional markers that hopefully will expand their interest beyond just tumor mutational burden, beyond just MSI status, and even beyond just PD-1. We're starting to see that there's a combination that it may be much lower risk. It's hard because most pharma just wants to look at a doublet or a triplet and go, all right, we've cured it. I mean, we're seeing that in the HCC realm right now, just, with atezobev and durvalumab, but not every patient is a slam dunk with those two. And so that's why I just try and continue to motivate, IRs and surgeons who are interested in this, stay in the game. There is a percentage of patients that you will play a huge role on, and don't just kind of feel like you're being steamrolled by pharma, and it's not the panacea, but it requires persistence, I guess, maybe as a way to kind of finish that statement.
Yeah, like stay in there. And, in parallel, technology is getting insane with AI and everything like that, where, a lot of mathematical model. I mean, I think we're going to see a big development of pharma and other options available to us. And in 10 years, I mean, maybe just 5 years, we're going to see a big change. So
we've had fits and starts with radiomics. We thought we had a really good collaboration with Tempus around this about 3 years ago during COVID, really helping us assess response rates to Y90 for HCC pre and post. It just, unfortunately, we didn't do maybe as good a job as we needed to. So they kind of, maybe shelved it or put it on pause. But I completely agree. I mean, computer-aided diagnostics, and that's a really broad term, is an untapped area that will make us, you and me, way better in regards to predicting response, how good a job we did, all those types of things, which needs to happen sooner than later, I'm hoping.
Well, as we wrap up, I mean, any advice you have for, young surgeons, IRs, we touched on some points, but any kind of big kind of points and things that you wish you had known, or you kind of tell all of your trainees as they show their wings, that they should know?
The main thing that I've always said, just because, I always say yes, take the appointment. It's only 20 minutes. Now, I say that, but there's a big caveat with that, because, when I graduated was before all of the massive conflict of interest and all of that debacle within the medical community. Whoever was responsible for it, not where I'm going. But obviously that has changed a lot. And so now it's looked like you're maybe selling out if you're having that conversations. What I always tell people, take the meeting, learn something. I guarantee you're going to learn something about that. And then the other part of that is a lot of times those meetings, they don't know where that technology really fits. And so IRE, a perfect example, drug-eluting beads, they presented IRE to me because they wanted to figure out how they could get in with the urologist. And I was like, I don't care about prostate cancer, but pancreatic cancer, this is a massive unmet need. And so I say, take the meetings, but then figure out in collaboration where it fits on the oncologic algorithm. Because not every technology is going to be that sweet spot, or that technology is only going to help 10% of the patients. And so I've always loved it, and I've always gotten energy out of it, because it also challenges me to think, all right, am I doing the right thing now? Just because I've been doing this for 5 years, does that mean, and so, I come back to the summarizing, just have that growth mindset. I mean, surgeons are the worst. Don't get me wrong. We can be very rigid. We can be very difficult to deal with. I'll own that. But I would say to not just young IRs, surgeons, but I would say also to young tech people who are trying to get into the business, you're just trying to find that person who you can hopefully collaborate and learn from. And then it's not going to be a panacea, but it's been hugely, I don't regret it. Have I failed just as many times as I've succeeded with certain devices that I thought would work? Oh, totally. But I think we're better off for it, as opposed to saying, wait a minute, I can't resect. That's not a resection device. I'm not interested. No. Because you and I both know we want to have a smaller and smaller percentage of patients who need to have that big midline laparotomy and need that 4 to 10 day hospital stay. If I could choose between a minimally invasive approach with the exact same outcomes versus a maximally invasive approach, I think we know where we would all go. And I think being part of that maturation and solution, I think is our responsibility. And so that's why continuing to learn, I think, can help.
Yeah. Well, that's great advice. And honestly, thank you so much for coming on today. I think that was a lot of great info, and thanks for being here and taking your time.
My pleasure. Again, I'm very interested that you all were interested in just kind of talking. It's obviously it's a passion of mine, and and I still love doing it. So that's fun.
For anyone who has any questions, feel free to reach out to us. We can connect you with Dr. Martin if you want to. So thank you.
Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable_onc. That's _backtable_ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
music by Aaron Bowles.
Thanks again for listening. See you next time.